All right, welcome to Knife Skills Live. It's Sunday afternoon on the long weekend, and once again, we're here with Tommy Chan, best bud, and we're going to be talking about physician burnout, really healthcare worker burnout in general. You've probably seen many TikToks, YouTube videos, those kind of things where people are quitting their jobs in the healthcare system, both doctors, nurses, and everyone. And I think there's a real challenge that we're being faced with when it comes to healthcare right now. And I wanted to start off just by proposing this idea, Tommy, and this is this concept of, do you think it's hard for people to really know what they want when they need to decide to become a doctor or nurse or go into that profession? Because you make that decision so young, don't you think?
Yes. Yeah. Like you have to prepare like in high school or in undergrad, right? But thanks for having me first.
For sure.
Thanks for having me again. And I'm your frequent guest and I feel honored. And I just want to say thank you. And it's always a pleasure to do live sessions with you to talk about medicine. And even like today's topic is quite interesting about burnout in healthcare workers, particularly in residency or in training, right? So I think this topic, when one decides to go into medicine, I don't think they would consider burnout being an issue or being a concern or a problem that they would encounter. Because in medicine, I guess you're just so focused to trying to get in your knowledge and then trying to get all your tests done and then trying to get all your experience. And then nobody really talks about the burnout part until you're in training.
Yeah, and I think residents themselves are faced with kind of an interesting challenge because you're a brand new doctor, you're just starting in your career in a lot of ways, and yet it's going to be the worst time. Like the hardest part is always the beginning. And I think many careers are like that. Nobody really talks about it. Nobody really says, hey, these are going to be the hard years and you'll eventually do better. And so, yes, and I guess there's two things there. One is, should it be easier for residents? And is it important that we make that part of the training easier? And I'm someone who's involved in resident training, and residents will watch this for sure. People I've trained will watch this, and so they'll be interested to see my opinion. I mean, I personally, I'm kind of torn because I think residency's got to be hard in order to prepare you for the challenges of real life practice, because it's not easy. You don't want the hardest time to come after your training. You want to have the hardest time in your training to be prepared.
I think so. I think I'm also like that in the sense where like I feel like it's getting that work-life balance is already very difficult, and working long hours and be able to perform at your best at your job, it's so difficult. But again, I think when you're at that age, assuming after undergrad, your body should be able to handle a little bit more in terms of a few nights of sleep deprivation, working long hours. So to me though, I feel like it should still be part of it. But even when I went through residency training, they just changed from that you have to go home a certain time after, let's say you're on call, for example. Let's say if you work 26 hours straight, that's like the cutoff for, let's say in medicine specialty, surgical specialty, even though that's probably the case. But let's say if there's another case that comes through the next day, an urgent case or trauma case, and then you want to learn, you want to be skillful, like even though you're supposed to go home, a lot of my colleagues would decide to stay and work on their off day or post-call day because, hey, this is an exposure and experience, and this also may resemble what I have to do when I am a consultant or staff in the future. So I don't know. I think it is also specialty dependent. I think like me and you are trauma surgery, as we're doing the live right now. In fact, Rich is on duty.
I'm actually on call right now.
Yeah. So technically you're working as well. So, and I just came off a 26-hour call, but I also worked the entire week, and I'm going back on call tomorrow at 8:00. So it's still long hours as a staff right now. But now I guess you kind of know how to prepare for it. That's the biggest difference compared to before. You just, I have to do it. But now you can prepare for it. What do you think?
Yeah, so being on call in my position is a challenge because you decide how much you want to be on call. Like that's one of the things you have to do as a consultant. You have to really choose how much you want to work. And so there's always pressure to do more.
Mm-hmm.
We got to make sure patient safety is number one. So it's a fine balance. Now, no matter what you do, if you're going to do a surgical specialty, there are going to be those times where you're absolutely going to be in a situation where there is stress at night, where you have to make judgment calls at night, and you're not going to want to necessarily do something, not necessarily going to want to do the right thing because you're under distress, you're under fatigue. So you need to train that a little bit as a resident. I think it's very, very important for sure.
But I guess the question it's the topic's on burnout today, but do you think that the burnout is because of being on call is the biggest part of medical training that causes burnout? Not the number of years in training, not the number of hours that you've worked that day, rather than in addition to that, you are sacrificing weekends, long weekends, like us right now is long weekend this weekend and we were both working. And then that itself can disrupt the day after, right? It's not just the day that you're working, you're on call. So do you think that is the reason, is the call shifts? Because I want to share my experience after I hear from you
For sure.
about my, again, I was trained in Australia, how their system is a little bit different. And also I want to mention some places in Asia, and I know our listeners are from all over the world, where their call shifts are like 48 hours straight. So I want to hear from you. Do you think it's the call, being on call causes burnout?
So I actually don't think that's the cause of burnout. I actually think burnout is a more insidious problem than that. I think it's a mismatch between the expectations that someone has when it comes to what their career is going to be like, what the opportunities are going to be like, maybe even the financial rewards, and what they're actually living. This gets back to my point earlier. You got to decide when you're very young as far as what you want to do in your career, right? So I think that's the real source of it. But the call is a problem. It's worth mentioning, there's an old joke in surgery. They said the only thing wrong with 1 and 2 call is you miss half the good cases. Now, obviously you can't do 1 and 2 call. You'll lose your mind. It'll be too much. But I think it's actually really, really relevant because at the end of the day, that comes from this mentorship model. So when residency first was created, the concept was that you would shadow and work one-on-one with your experienced doctor, and you'd basically live the same lifestyle they lived. Now, they were on call all the time because that was essentially the type of hospitals they'd work in, smaller hospitals. They would do every operation they could, and it was like 24/7 call. But recognize they still had family lives. They still had all those other things. The system was very different in 1910 than this healthcare system is in 2023. And so some of this stuff is a hangover from this mentorship model. And so we think that, oh, residents have it easier now. I'm sorry, they don't. The residents are in the hospital, in a lot of ways, running the hospital when the consultants aren't there. And that model was not how residency first was formed. It definitely, there was a period of servitude to the doctor you're working for sure. And that apprentice-apprentee model, mentor-apprentice model is the cornerstone of what's true about healthcare and medicine forever. But also recognize that we've shifted to a point where the residents are actually a key cog of the healthcare system, and they're spending as much time contributing to the healthcare system as anything, right? It's a different model than what was happening sort of turn of the century. So recognize that we can't compare the current residence experience to even 20, 30, 40 years ago. You think you can, but it's very much not the case. Residents are doing a lot more of the day-to-day hard work as well. I can think of many other points, and I want to get to that as time goes on. So we're going to explore more of these things. What's your thought on?
I think I agree. I think burnout is probably analogous to you running on the gas of tank, tank of gas, sorry, where over time call is one component of contributing to the burnout process. And also, do you see the light at the end of the tunnel? You kind of just work, call, job prospect, working with different healthcare workers, getting along with people, patients, family, studying for exam, preparing for more training. So I agree, all those components add on to the burnout. And I think also looking at, let's say I was looking at other countries I was telling before. When I was in Australia, and I still keep in touch with my colleagues in Australia, the word burnout is never brought up though. That's why I was asking you about being on call, being call duties.
So how is the call different in Australia?
So in Australia, there's like most specialty, not all, do not have a call system. They have a day shift, night flow, similar to how nurses work in the hospital. So they would work days that are 12 hours and they have a night flow person. So they still might have to work some weekends, but their sleep cycle is not disrupted because they know that for those next 2 weeks, they are on a certain schedule. And it's probably protective because another part of burnout, it's your lifestyle is completely disrupted, right? If you don't sleep well, you don't eat well, you don't exercise well, mentally, you're not going to be well. If your mental state is not well, that's when you think about, oh, I'm running out of gas, right? I think it's a mentality too about burnout. I don't think it's something that you can see or feel at that moment. It's a mental state. I'm like, oh, this is just too much now, right? So I think that's why, to me personally, I think the call system is a major contributing factor to the process of burnout.
And it's hard because the call system is there to help us cover patient care, which is hard, which is a hard thing to do, right? We have to, at the end of the day, provide service to our communities. And for a hospital like mine, which is a tertiary care center, specialty care center, you need to have the residents involved, and we got to be busy enough to get the more rare and complex cases. You have to have enough volume, which means we've got to be working and accepting patients from all over the region. We have to have, subspecialty care. We have to have a lot, big hospitals, and they depend on residents in order for us to have the unique patients that the residents only going to see once, so that they're ready to be out in the community and provide that type of care independently. So it's a very important part of that. So it's a catch-22, I think, in a lot of ways, right? You need that hard resident work on call in some ways, because I think truly in a lot of these systems, night float would be great, but it won't work in every specialty.
So you might miss a case where you need to be good at to be competent in your specialty. But can I bring up? Can you
even staff the hospital with night float? Like, is it even? Do you even have enough?
So people? That's the difference, right? So like in the last video we mentioned, in like some Commonwealth country, there's this models of internship and house officer before you get to a specialty. So there's more medical providers, which is a completely separate topic about should we hire more, have more positions for medical school and trainees and foreign graduate. That's a different topic. So it's a volume thing, I agree. Two, a question back to you is, so do you think, because that we're entering competency training now, meaning that a lot of specialty where it's not like, hey, you want to be a trauma surgeon, 5 years you're good, or neurology, 5 years you're good. No, you can be done in 4 if you're able to check off the boxes of, hey, I've done how many procedures, I've seen how many of these cases, right? So does it mean, though, the question I have is, does it mean that the more hours you put in equate competency training?
That's actually a really good question. So that does not equate to competency training. We know this. So, and Canada is a leader in competency-based medical education. In general surgery, we have that. Actually, really all specialties now are fully competency by design. The problem is that the way healthcare is funded and the way residency positions are set aside, 6 years, right? So we need all that, right? So yeah, I don't think they equate. But then this gets back to, again, it's expensive to train residents, although I would say a resident is cheaper than a consultant at the end of the day for the system.
Oh, maybe right? Residents is probably even cheaper than other healthcare workers, one would argue.
Well, this is actually that point I wanted to make. And I struggle with this one because I think, and I'm not trying to, we're not here to make any political points here. We're just here to kind of talk about our experiences and just see what other people's thoughts are. Those people, by the way, feel free to ask any questions in the live chat about if you're someone who's interested in medicine or contemplating or having anything. We're just very happy to just answer any chat questions. and get your thoughts. But what I was thinking here, really, Tommy, is that the one of the challenges is how do you differentiate yourself as a doctor from, let's say, a nurse practitioner or a physician assistant, those types of professionals? Because if you water down residency, training becomes shorter, 4 years instead of 6 or whatever it ends up being in a competency program. Where do you find the differentiator between people who've done less training? I mean, at the end of the day, my attitude is residency needs to be hard in some ways to separate those of us who've done those training and arguably, demand a higher per hour rate or higher per patient rate than someone has less training, right? And so again, that may be a political thing, but at the same time, I think people who are doctors would expect a higher income than a mid-level provider. And again, not that they're not doing a great job, but in order for doctors to be differentiating, they need to be, first of all, either more efficient. Let me think of a good example here. So if you're someone who's got a chronic pain headache, you're a patient who has a chronic pain headache, this healthcare system benefits by them seeing you, because you're going to come up with a plan that's going to keep them out of the emergency department, that's going to keep them maybe less dependent on opiates or whatever strategy, right? And that'll save the healthcare system money. And so your additional expertise is actually resulting in more efficient healthcare system, right? And that's the value. But that only happens because you have subspecialty training. You've done 6-7 years of postgraduate training to get to that level of skill. And so we do recognize there is value of subspecialty training, being very specialized, that can save the system money. And so those are some things that are important. But that is the result of demanding training, right?
Yeah, I think there's no way around that. Like, to be competent in our field, in specialty training in particular, hours will be long. It's just cumulative hours going to be long. And I think really go back to that first question about the burnout. So I'm sure there are other things that I guess maybe Rich, you can share your experience, or from your colleagues even. How do you counteract that, the burnout? Let's say that does crosses someone's mind. They're feeling it. Like what I would say, everything kind of are connected in some way. They're in the mental state of, hey, you know what? This is too much. What am I doing? I feel tired. I feel lost.
Yeah, so I think a couple things. You do need to keep the goal in mind, the end in mind. It's really important. You need to know what what your dream is, what for you added in. I was thinking that probably the absolute best person, I'm having a little bit of technical problems here, probably the absolute best person to be a doctor is someone who comes from a family of 100%. And
if you still decide I want to do it, you kind of know what you're getting into, right?
Absolutely.
So I think that is true, because I never thought, I have to say, going back to like the very, very first question, I never thought that my day-to-day life would be like this as a doctor right now, to be honest. It's not a good or bad thing, because you're right, exactly right. I felt like, at least back in the days, like being a doctor was like in the TV show, right? You go to work happy, you're always energetic, you're going to be able to socialize, interact with a lot of people, also at the same time help people, have good income, and look good and everything, right? But then you realize there's so many things that, first of all, they don't teach you in medical school. I think they're trying to do that a lot more now, to give those lectures or sessions. But it comes down to that personal experience and your mentorship, I think, because a lot of times this might be taught in classroom. I don't think that will that could resonate with the students, for example, at that time. And so I think that mentorship, also with earlier exposure experience to this field, whatever that may be, will obviously help the process. And so let me ask you, because Rich, you did training in family medicine.
I did.
You also did training in general surgery, and then you went to trauma surgery. Was there any point in those training where you felt like, you know what, because I'm doing this specialty, I'm feeling I'm burnout, or it was a cumulative things over the years that you've put into training, or you know what, like maybe in family medicine, because it's more general expectation. I'm not saying which specialty is better here. I'm saying that maybe that I have to know general medicine rather than everything about specialty. So pressure might not be as high. Like what is your experience?
No, that's excellent. So as a family medicine doctor, I had a different experience than surgical. So first of all, when I was a medical student, I wanted to do surgery, but I knew I was going to be doing family medicine. I knew that. And I remember like going into my surgical rotations thinking to myself, what an awesome job. It's a job I want to do, but I don't think I can actually handle this residency because you're up at like, well, you had to be at the hospital at 6 a.m. You're not leaving till 7 p.m. You're like, this is a 13-hour day. Like, and it's every day. Like as a clerk, it was fine because, you know, I was only doing it for a few weeks at a time, but I was going to have to do it for 5 years plus a fellowship if that's what I wanted to do. I was like, I don't know if I can even like handle this. I was like, this is crazy. I'm not sure I can do it. So I went and did family medicine. And when I was a family doctor, I remember thinking to myself, I am so ready to be out of my training and into independent practice. I wanted to be done so much. And I don't know what it was. There was something about being on off service rotations all the time. In family medicine, you spend half your time off service. And like I wanted to do a lot of emerge and those kind of acute care stuff. And you know, I was only had so many opportunities when I was doing the family medicine training. So it just had this feeling of like sort of a constant desire to get out. When I was in general surgery, I didn't feel that way at all. In fact, in some strange ways, I'm like, I want more training. I need more before I'm ready to be the guy doing the surgery on my own, right? So I ended up doing a fellowship and I ended up actually working where I trained. And so I had a lot of mentors and people supported me. So the way I thought about it was really, really different. Like my perspective on surgery was different.
I think that's exactly what you were alluding to before. It's not the hours or the actual call that were burning you out. It was more that goal. It's like I have my goal in mind. I want to be a surgeon. Hence, I want to be a very competent academic professor and clinician. Therefore, I'm going to put all these hours in because I do see the light at the end of the tunnel. And you met great mentors along the way who say, hey, listen, you're doing all the right thing, keep going. And so I think that is how you counter the burnout process, is having that goal in mind, light in the end of the tunnel, mentorship program. And I think that's really what they're trying to do now. And I think when you were probably as a family physician or in training, and again, some people might know exactly what they want to do in family medicine and also do some specialty training within medicine. But some of them may just, hey, I just want to be a doctor. And then there may not be as goal oriented. Again, this is not a general statement, but some people may be. So that may also play a role, right? As in like,
yeah, being like, I want to be a doctor even makes sense. Like I want to be a doctor. There's so many different jobs. Like there's so many different things you do in medicine, and just saying you want to be a doctor doesn't make a lot of sense. It's a little bit like the parents that put pressure on people to like become a doctor. It's like, what does that even mean? Like literally, what does that even mean? Right? Your job and my job are really very different. We're close because we can relate to our lifestyle a little bit. We have some similarities, but you know, the day-to-day problems I deal with are very different from the day-to-day problems you deal with. The way you interact with your resident team is very different than the way that I interact with my resident team. You know, a good day for me is very different than a good day for you. And so, right, like you got to know what you're getting into is the right fit for you. Otherwise, it's going to be a real problem.
Exactly.
And a little bit, you know, that comes out when you're talking to residents who are applying to a residency training program. Some of it really does come out, and you have like we are thinking, you know, does this person, are they really a good fit for this specialty? That is something that weighs in. And we try not to be biased, but if you're interviewing someone and the impression they give you is, you know, the types of things they're interested in, the lifestyle they want to live, the experience they've had prior to applying to the program don't seem to fit very well with being in that program, you're going to be less likely to pick that person because you want them to be successful. We want the residents in our program to be the most successful they possibly can. We pour our lives out into these residents, and we want them to be the best they can be. And if you're better off in another specialty, then that's where you should be.
Mm-hmm. And I want to go back to the topic of the burnout. Let's say that during COVID times, this topic of burnout was all over the media, right? Particularly with even not doctors, like nurses. And I think that their process of burnout in other healthcare workers might be different than I think doctors. Because, for example, I want to just highlight, let's say nurses had to really work very, very long hours, physically very demanding, wearing the protective equipments and masks all day, short staff, so they have to handle more patient load. And then I think in their field, their burnout it's directly related to the hours, these lifestyle changes, sleep deprivation, and labor, right? All of those are kind of, I guess, as a doctor, you might also experience, but in addition, there are other expectations. For example, when we go through training, where you have to be able to teach as well, you have to do some research, let's say throughout training. You are expected to finish the task despite you're home now, as opposed to you're going to go to your shift and you do your work, you go home, it's done, right? So I think that even though burnout may be seen across the healthcare, and especially in the past 2 years for other nurses, they did an amazing job, and it was very, very difficult for them, for sure. But I think that the definition of burnout is different. Doctors versus, let's say, nurses versus other healthcare providers, depending on their situation.
Well, that's a great point. I mean, we're right now struggling, I think, all across North America, really, with not enough healthcare providers. And that is a very serious structural problem. Again, I don't have solutions, but you have to understand is that we're in a period of time where there's been a lot of economic changes. Personally, there are lots of great jobs out there that are stable, that pay well. If you are in an environment where the unemployment rate is 3%, which it is right now, that means people are competing for talent and labor. And if you're someone who's trying to decide on a career, you're going to say, well, am I going to go and do healthcare, or am I going to go and do business? Or am I going to become a pilot? Or am I going to become an engineer or some other job, right? We're competing for talent across the pool, right from the person who's doing janitorial work at the hospital all the way up to even the executive talent. The healthcare system is competing. And if we're in an environment where there's job opportunities that are in other places that are going to be paying better, having a more normal lifestyle, less call, less night shifts, those types of things, you're going to lose people and talent to those other jobs. And inflation actually hurts us, because I think healthcare in general is going to be a slow responder when it comes to income raises compared 100%. To, let's say, private businesses. And so you'll see people literally looking at the opportunities. In Canada, it's a joke. It's like, you know, what do nurses do when they leave the hospital at the end of the day? They start showing houses for real estate. You know, there's like, I don't know if you had this experience, but there's all these people in healthcare who got real estate licenses over the past few years when the market was hot and they were selling houses. And so the reality is, it's an example of real estate literally competing for talent against the healthcare workers. So it's a real legitimate challenge. So some of it is pay, some of it is autonomy, work hours, some of it is really like expectation management, some of it is just wellness that's just not available. I mean, again, this goes back to the issue of physical conditions. You're in a mask, you're sweaty, you're not able to interact with your patients. Like, you lose that human touch when you've got a mask on your face. And in North America, most hospitals are still mandatory masking, and it's going to change. It's not going to be there forever, but it'll be there for a while. And if you're someone who really wants to connect with your patients, it's hard to do that when half your face is covered. So even masking itself, I think masking itself and those policies that are in our hospital are having an impact on the satisfaction that healthcare workers are having when they're interacting with their patients.
I guess like because you're eliminating a part of your body language where it helps with social interaction. That's a very interesting part of the world that we live in right now, right? I think that we are adapting to a different way of practicing medicine with COVID. I guess I'm not sure if we call this a post-COVID period or we're still living in the COVID period. We don't know. So I think that's a tricky part. But wellness. What about wellness? Because this word has come up so often in the past 2 years about different programs, hospital system. Hey, we want to promote wellness. Even I'm very involved in our resident body. We actually have resident assigned to be the wellness leader, or to ensure that this is part of the curriculum now. What do you think about the word wellness and how to execute and implement this in, let's say, training, okay, and also within their healthcare system?
Well, the one thing that I thought about when you said wellness was the fitness facilities that they put in our hospital recently, and that's a bit of recreation. Now, that doesn't work for everyone because not everyone is into fitness. But if you like fitness and you can go to the gym and you can, on a break, even a 15-minute break, well, that may not be long enough, but certainly when you're taking a lunch break and you can go get some fitness in, that can be great for wellness. So I think wellness programs sometimes are having those things available for people to, decompress while they're at work. But really, if you think about it, like how do you implement wellness? Because everyone's perspective is different.
Yeah.
Maybe someone needs a place to meditate. Maybe someone, wellness to them is actually, having a consistent work schedule or patient load that's manageable, right? Right. It's like wellness sometimes is very simple.
It's very subjective.
Yeah.
It's very subjective. And so I think like the gym is obviously, for me, it means a lot. So for me, like that is like, wow, that promotes wellness for me, like 100%. And I try to push that to my resident group. But like what you said, some of them are, hey, that's not what makes me feel good. And I think having the avenues and having those options available, it's a good start, first of all. What do you think about, and this kind of, it's something what other industries are doing, about the number of days work week from 5 to 4. They may have to work 1 to 2 more hours per day, a little bit longer, but they get every Friday off. And they have done that even, let's say, some of my friends who are working in Toronto in the summertime, even before COVID started, they would have summer week, meaning that they only work Monday to Thursday and then Friday they're off. So every week is a long weekend. But now there's some jobs where companies, they are saying that the efficiency, right, of productivity much better 4 days versus 5 because of that balance that they could maintain for the work-life balance or the wellness. What do you think about that in healthcare?
So the compressed work week idea, I mean, well, doctors have been doing compressed work weeks kind of forever. There's also another joke. I'm just thinking of all these things. Like in one of the communities that I worked with, people used to say, does any doctor work on Wednesdays? Like they're all at the golf course. Everyone's golfing on Wednesday. So, and we have friends of ours who have found really a lot of success in their career recently by switching to a 4-day work week and working Monday, Tuesday, Wednesday would be maybe a min, or they could do some personal wellness, and then on Thursday, Friday, they're back to work. So I think a compressed work week makes a lot of sense. For me, wellness is autonomy. So, I work every day, but the pacing, I have a bit of control. If I'm feeling like I'm a bit overwhelmed with my academic work, I'm going to back off on my clinical responsibilities, and I'm going to take on less. And I'm fortunate because I'm at a stage in my career where I can have a bit more influence on my schedule and can do that. So, I'm always kind of sensing, where's my energy level at? How am I feeling? How, am I feeling burnt out? If I am, I'm going to be scaling back. And this gets back to that individual power. If you're a resident, you don't have that. If you're a nurse, you may not have that. And so those are some of the real challenges when it comes to wellness. Again, how much autonomy do you have as an individual? And depending on where you work, those opportunities are limited for sure.
I think you're completely right. I think the word burnout, it's different when I was, at least for me personally, different when I was a resident versus when I'm a staff or attending or consultant now. burnout that I had as a resident, the call and the hours were a huge component. That's why I brought that up. Now, it's really more on the responsibility. That's a burnout, meaning that because I have to wear many hats as an academic physician, I'm expected to deliver or perform and always be at the top of my game, as a subspecialist, for example. And if an individual always have to be at that state, like a game shape every single day, at one point it's just like an athlete. You're gonna be like, this is too much. I'm gonna get injured. But in our case, injured not meaning spraining an ankle, but like mentally be like, wow, this is just too much. How can I just keep doing this day in and day out? As resident, like what you say, you don't have options to say, I play golf on Wednesday, I plan my schedule around. But as a consultant and staff, I can. I don't do clinical duties every day, but I work every day. I work every day because, like what we said, we have other responsibilities and duties. And so I think that's why the definition of burnout changes over time. And so what's your experience?
Well, it actually reminded me, this isn't even really the topic today, but, doctors have had a high rate of suicide. And this will probably like get my stream canceled just by trying to talk about this, but we're going to talk about this in the most academic way we can. But they've self-harm behaviors among doctors is a well-known problem. And again, this is related to burnout issues. And I mean, I have had more than one personal experience where friends or even people who were who I was getting care from actually as doctors have killed themselves. So I know 2 people personally, and not in less than a 3-year period that have ended their life as doctors. And I don't know why, what the cause was in each case. Obviously there's underlying mental illness, and there's no doubt about that. But there is something about the pressure of being a doctor, the fact that we see people suffering. You can sometimes feel hopeless as a doctor because we deal with people at the end of their life all the time. And unfortunately, doctors are this high-risk category. And nowhere else in my life, I have friends outside of medicine, had a normal upbringing, regular high school experience. Nowhere in my life have I seen this number of tragedies in my life other than people who are practicing medicine. And so
I think there's so many layers to it. I think there's so many layers to it, and I think there's stigma around this topic. Obviously, as a physician, you always have to be in game shape, top of your game. And if you talk about that, you're vulnerable, you're weak mentally, that it's not going to go well with training. Like, that's kind of the stigma. I think that we're doing a much better job, to be honest, where I've seen that over the years. And again, kind of along the way of burnout, that's part of it, right? Like a poor mental state will lead to burnout. Okay. Like no doubt about it, part of it. And so I think that, it's good because I think the society is accepting that a bit more. There's less stigma around it. And also I do see it even through, now that as a staff attending compared to when I was in earlier training, people are more vocal or willing to talk about. Program directors and leaders are having informal sessions just to kind of check in on trainees or even colleagues. Hey, how are things? And so I think that we are heading the right direction in some ways. And I think that like what you said, I don't think that's a one size fits all. I think that avoiding burnout or at least mitigating it, it's the choice, having autonomy, options,
Absolutely.
support, and being very goal oriented. And also there's different checkpoints that one should have where like, hey, let's just evaluate where I'm at in my life. What do I want to do? Am I doing the things that I want? I think those are the key elements to, again, mitigate the process of burnout. So, and
good health behaviors. I mean, I would also really advise truly very careful use of alcohol and other substances if you're practicing in medicine. It's very easy to lean on alcohol, and there's a high rate of alcoholism in doctors for sure. And one of my mentors always said, you know, alcohol is the greatest thief. It'll steal your life because you think you're having a whiskey or something at the end of the day to relax, and that can add up. Now, you know, we both drink. It's not that I'm saying don't, but I'm saying very important to have a healthy relationship with a drug like that, because
it's all about balance.
Absolutely.
Oh, everything is about a balance.
Self-assessment. Am I using this to cope with other problems in my life? And it can sneak up on you. And so good health habits are very important. Limiting substances, maintaining exercise, and that may not be hitting the gym, doing deadlifts and that kind of thing, but you do need to get your heart rate up. You do need to do those physical things to keep you well and healthy. It also is about eating properly. It's very easy to eat junk when you're a doctor. And I'm the first person to end up grabbing fast food after a long call shift.
Can I bring up a point? And this frustrates me because you brought up about, obviously we talk about diet as a huge component. Again, this could be a whole topic on its own.
I think we will do a podcast a little more down the road when we talk about diet for sure.
Because I recall that when I was earlier on my training, my diet was the worst. Okay, it was terrible the first 2 years. And again, like maybe there's sometimes you'll go for happy hour, some alcohol consumption, you eat fast food, pizza, wings, chips all the time. And I was at the worst physical state of my life in first 2 years of training. And I realized my other colleagues were also going through the same thing. Not everybody, but a lot of them. And now that I'm as an attending and staff, when I see the earlier trainees, there are people who, once they start training, because it's a completely different lifestyle and routine and schedule, it's completely disrupted. They lose that part of their life. And there's a saying where like not saying, but like people share that about 20% of residents, I'm not sure from your personal experience, which you agree or you've heard of this before, 20% of the residents gain 20 pounds in the first 2 years of training. And I was just thinking that number seems pretty high. So 1 in 5 people gain 20 pounds in the first 2 years of training.
Yeah, I can't speak to the stat, but well, I can tell you from my own experience. When I was in my 5th year training for my Royal College exam, or the boards as would be known in the American viewers, that is a very difficult time. You're like studying all the time. You're focused. You're in the books. And I have some photos of me, and I definitely have a pudge for sure happening. So I don't know if I was 20 pounds up, but I was definitely overweight during that period of time. And you're absolutely right. And why was it? It was because I wasn't prioritizing my own health. Now, we all go through those periods of time. And that was a time where really I did need to prioritize studying. I had to prioritize honing my craft. At the end of that year, I was going to be an independent surgeon. I had to be able to pull off certain operations, and that's a challenge. So I had to go through that process. But at the same time, I knew after that, I was say, okay, I'm done. I'm going to get in better shape. And then actually spent the next year getting in the best shape of my life. So ironically, within 1 year, I was in the worst shape of my life. And then I was in my absolute best shape of my life.
So welcome to medicine. That roller coaster ride that you go through, right? You just go through the ups and downs really in life, and also your physical state and your mental state. You go through the ups and downs.
But it shows the difference between being a trainee and being a staff, right? Once I was able to get past that trainee phase, I had more control over my life. I was able to get in the shape I wanted to get in. I was able to take care of myself a bit better.
So there's light at the end of the tunnel.
That's the point I'm trying to make here. That for anybody who's watching this, resident-wise, I do think it needs to be hard. I do think it needs to be a challenge. I do think it's important that you push yourself during residency. Very important. You got to be prepared for those difficult moments. But it does get better. And that's why I always say, and I made a video a few years ago, maybe a year and a half ago now, about don't quit. And the point I really was trying to make there is try to get to that next stage. Because if you're finding med school tough, residency is a different experience, and you're going to have different challenges, and you'll find yourself reinvigorated in residency. And I think if you finish residency, get through that, you're going to find consultant life different and better. Now, if you do believe genuinely that healthcare isn't for you, that's a different thing altogether. But if you meditate on the issue and what your goals are, and you really do want to be a doctor, and you're feeling overwhelmed, it's okay to take time away, and it's okay to get support. But I do think it is worthwhile to get to that next stage. If you're in med school, try to finish and get that medical degree. There'll be good opportunities for you if you do that. If you're in residency, especially if you're later in residency, try to get to the next stage. Now, again, maybe it's a program change though. Like I've had lots of people who said, you know what, surgery's not for me. And if you're in surgery, I'm telling you right now, it may not be for you, and that's okay. That's okay. Even that might have been your dream. That's totally fine. I really do encourage you to take a step back, try a different specialty if you're finding surgery difficult, because there are 1,000, not really, but there are many different specialties that you could choose, and there's a place for everyone. The person who makes a great pathologist is going to be a different person that makes a great surgeon. The person who makes a great family doctor is going to be a different person than the person who makes a great neurologist, right? They're different types of people. I really do believe that. And so I encourage you to consider those other opportunities in medicine. Stick with it, but again, there may be another place for you within the field if you're struggling in one particular area. And again, what is it? Why are you struggling?
Yeah.
Right? Yeah. Surgery might be, I don't enjoy the operating room. Well, if you don't enjoy the operating room, you're like genuinely, I don't like being in the operating room, then surgery is not the place for you. But if you're someone who loves the operating room and you're passionate about that, but you're finding the hours difficult and you're tired and you're stressed, then, you know, there may be other ways to help cope with that so you're ready for practice, right?
Yeah. I think, Rich, you brought up a good point about, like, don't quit. And I couldn't even count more than, like, my fingers of how many people I know actually quit medicine while they're in it.
Like, I know completely.
Oh, completely.
Well,
I've known a lot of them that switch specialty for exactly what you just said about, it's navigating about their personality with their interest in work-life balance.
Well, I want to pause here for 1 second, and we'll dovetail on this. One of the inspirations for this live podcast that we're doing today was the fact that pretty much everywhere you go on YouTube, there's another doctor quitting, and they're essentially YouTube doctors quitting, residents or med students who are successful on YouTube that are saying, I'm quitting medicine, I'm doing something else. That is a very different animal than the person who is not distracted by having this YouTube hobby or something and quit. So I really want to point out that you may actually be getting the wrong impression if you're using social media as your standard of how burnout is affecting people. Yes, burnout's happening a lot, but the people who are posting about their burnout on social media are like a unique breed. They're people who are social media people. And I think when you are someone who creates content, and I love to create content, there is I don't want to say a distraction, but it's a different world that you're living in. You're interacting with different people if you're creating content. Your perspective on what you're doing with your time off is a little different when you're creating content. So I think that is a unique person. And if you're watching this and you're thinking every doctor's quitting, everything I see on TikTok, everything I see on YouTube where doctors quitting, that's not actually true. There are a lot of people suffering with burnout. That's what this is about. But quitting to have a social media career or quitting to do another job is not that common. That was a comment I just wanted to make, because you said you've only thought about 2 people that you know. And tell me more about when they quit and what their story is. Obviously, you know, respecting their confidentiality.
In med school.
In med school.
In med school. So I think that, I think there's 2 reasons. One is that we don't know if, because they had issues about applying to residency, could they have not matched to the specialty that they wanted. And
they discover that in med school, because I do know people who've quit because they never did get a match.
Yep.
And especially in Canada, where we're from, one of the big challenges is that there's a whole bunch of people who are international grads, and you can check our last video about this, who have failed to match in residency programs. I think in Canada, we say there's 1,200, so 1,200 people who have done med school outside of Canada. That's going to be Australia, Ireland, Grenada, any of those places who have not been able to get a residency program. Again, this is a problem for politicians to decide, not us, but those are people who are Canadians that have med school training and haven't done a residency. It's a real issue.
So like they did quitting because they really couldn't match to a system where there's only so few spots. So that's one category. Another category, it's they never wanted to be a doctor since day one, but it was just pressured by family, right? It's like, hey, you have to be a doctor, and I'm sure that there are a lot of parents who they may be doctors themselves, maybe they're not, but they would put pressure on their children. Again, that is a completely separate discussion. Again, that could also lead to burnout for the individual, where because they don't have a goal anymore, right? Remember going back to the first thing we say, if you have a no goal, is you're going to burn out.
It's not their goal.
Yeah, it's not their goal.
It's mom's goal or dad's goal.
Yeah, exactly.
And actually, I have a friend of mine who became an engineer because his parents, I really want you to be an engineer. What he's ended up doing, he ended up working in, I think, not visual arts, but I was going to say more of a graphic design type of job. Got an engineering degree, but ended up working in graphic design, and probably would have been better off had he focused his training on that instead of going and doing a mechanical engineering job, right? But his parents wanted him to do that, and well-meaning parents want their kids to be successful. Say, push yourself and do all that, but at the end of the day, you're going to be successful. You're doing what you're passionate about, what you love doing, and hopefully, if that's medicine, then that's for you. Now, here's the interesting thing, though. Everybody quits medicine eventually.
Elaborate.
Well, we all retire.
Oh, yeah.
Right? And there are lots of colleagues who want to be prepared to retire at 55 or 60. Well, let's think about that mindset. Now, I don't even think about that, right? I'm 41. I don't even think about retirement, even though I'm making sure I'm preparing for it, because you have to as a doctor. Make sure you're preparing. If you don't, you're destroyed. But I'm not in my mindset looking forward to retirement. I do genuinely enjoy my job practicing medicine. I have lots of great opportunities. I have a lot of autonomy in my current job. I get an opportunity to contribute in multiple ways. I can create content here. I love doing that. It's a great hobby and it works and it fits well. Research, teaching, surgery, clinic. I have a great variety. So I love it. I'm not thinking about retirement, but we have friends of ours who are young in their practice who think about retirement all the time and are very much saying, look, I want to retire young. That's my goal. I'm going to try to earn as much income as I can, be as successful as I can as an investor so that I can retire young. Now, is that not any different than someone who says, I want to quit now?
Yeah, I think that goes to there are people who get their medical degree and then they switch career after they get a medical degree. They may do a law and they do medical legal things. They might go to pharmaceutical companies. They might start running clinical trials. I think that just to kind of build on your point about don't quit, the value of a medical degree holds its value. Okay. I think that for whatever you decide to do in the future.
That's a great point.
And I think that don't just think that medicine is what you see on TV. Okay. I could say right now that I would never see myself doing what I'm doing like 10 years ago, because I'm doing a lot of things that are not clinical, but also in medicine. So that's the part about the beauty of the medical journey is that is different for everyone. It's just not clinical. There's different aspects to it. And then you can build your career on your medicine. You can go on a detour. You can add this. You can try different things. So that's the positive side of you can be creative. That's the word. You can be creative in the practice of medicine and not just what you see on TV. Yeah. So I kind of want to give a shout out today too, actually, to one of my friends actually who his partner have a scrub company actually. You see probably on our what we're wearing today actually. Me and Rich, we're wearing our scrubs today. Is actually from Vina Wear. So we got our name on it, our specialty. You see Rich
Nice
here.
Skills logo right here.
Yeah. And shout out to Vina Wear. They're a Canadian company. And this is not a sponsor talk, but they gave us the shirt.
They're friends of ours, and we want to support them for sure. And they did give us these complimentary scrubs. We think they look great. They're fantastic. The price point is very affordable.
Oh, very.
Some of the more common companies that you might be aware of, they aren't producing scrubs that are unique in their quality. I think what they're doing is a very strong marketing campaign. And so if you're looking for scrubs that look good, fit well, quality's high, and the price point is better, then check out venaware.com. The link is actually in the show description as well. But again, not a sponsored video. We're just supporting friends. And actually, that's an example truly of creative
exactly
things that you can do. These people found a need. The pricing of scrubs, custom scrubs, is so expensive, and there's an opportunity to help out.
Can I also bring a point about, because I know we might have a couple of minutes left, about, because the scrub company, it's my friend and colleague's wife who owns the company, and I heard even one of my friends who is a neurosurgeon went on mat leave, and obviously became a mother, and then start developing baby food, but like organic and all that, and that became her passion. Like that was her business, and become an entrepreneur herself. And then she came back on mat leave, continued to practice as a neurosurgeon, but her passion fully is like, hey, I want to push this business forward. But then now, because I'm a neurosurgeon, my voice is much louder as well. That's what I'm trying to say about that. I mean, that career path.
Medicine is interesting about medical school too. It's a very general degree. You think it's not, but it actually is. We're covering nutrition, we're covering fitness in medical school, we're covering disease process, normal physiology. Like there's a lot that you cover in medicine to prepare you for your residency training, and the skills and knowledge you get from being a medical student and getting out there to practice in real life is quite useful. So the other part of it too is you're not trapped in a clinical job your entire life. There are many opportunities for you to work and be a doctor after your training is done. So it goes back to stick with it, because as you go through each step, get through medical school, doors open up. You get through residency, doors open up. If you've got some years in practice, doors continue to open up. So I strongly encourage you to stick with it for that reason. I might make a video someday about how to quit. I think that might be also really useful. Like when to quit. Like what is it that you should be thinking about if you are going to decide to quit, and some criteria, because I think people sometimes feel a little bit lost as to how far they should push it. And I know like I said, one of my better videos is this don't quit video, because people are looking for advice. Like, what should I do right now? Where am I at? And although this video has been about burnout and some of the challenges that are facing our healthcare system, challenges that are facing us as doctors, for the most part, I think it's a great career. I'm grateful that I've had this opportunity to do it. There are other opportunities, and there are lots of days where I'm like, I wish this, I wish that, for sure. It's a job. You're going to have bad days. That's normal, right? But for the most part, I'm really happy that I've done this career.
Yeah, we're working this weekend, but we're still having a good time, and we are being very educational. I think that's the part of medicine that's very, very nice.
Yeah, there's lots of opportunities, and we're excited about it. I think what we'll do is we'll probably end the live stream right here. Tommy, thanks once again for joining me, and thank you, all the viewers, for watching this video. This is Knife Skills. Please leave a comment on this video if you have anything else you want us to talk about live. We're trying to do a live a couple times a month, not necessarily on a particular day or a particular frequency, just to keep it flexible. We want this to be fun, not a job, and connect with you, the people in the community, the people in our audience, people who love medicine or thinking about medicine, or doctors in training, maybe med students, or even younger students who are contemplating medicine. That's what this channel is all about. So my name is Dr. Hilsden. This is
Tommy Chan.
All right.